Dr. John Venglarchik is a pediatric and infectious disease physician and professor. The information presented in this video is based upon current available published literature.
Okay, so children are a really important topic, and we're going to get to that. But first, I wanted to back up a little bit and just ensure that we cover how exactly is COVID-19 spread, and can you compare, if it's possible, how contagious COVID-19 is compared to how contagious other respiratory viruses are, such as the seasonal flu. And it looks like you have significant experience with this since apparently you've had it.
Yes, I have had it. I was infected in April as far as a family exposure, which is by and large the way that this is spread. It's spread in family units, and there's some good data out there to back that up from a variety of countries around the world. I was completely asymptomatic. I had no symptoms. I had no fever. I had no runny nose. I had no cough. I didn't sneeze. I didn't have any fatigue. I had no shortness of breath. I didn't turn blue. I didn't have problems feeding. I didn't have any of those particular symptoms. I was completely asymptomatic. My culture of my nose, which picks up the genetic material of the coronavirus, was positive. Interestingly enough, we do know that individuals, once they've recovered, as I did, can continue to have a nasal swab that's positive after they no longer can transmit the infection. I fit into that category that I tested positive for a period of time after, despite the fact that I had no symptoms, was past the 14 days, and this is well documented in the literature that swabs can be positive for up to 6 weeks after you've recovered from the illness, and I certainly fit into that category. I've been tested. I am antibody positive. I have immunity, and I have no doubt that that immunity is going to persist, but we'll talk more about that later. So I am part of the herd. We've talked about the names. I had it. I recovered it. I'm immune. And as a consequence, I don't need to wear a mask.
Okay, so this may be hard to answer. I know you like to really quantify things as a scientist, which I can respect, but can you say how contagious it is?
Well, let's talk about how it's spread, okay? There's different ways that we can spread germs, okay? And let's be all inclusive. I was there, this has nothing to do with this, but I was there at the beginning of the AIDS epidemic and would walk in the room taking care of patients that had AIDS when we really didn't know how it was transmitted. So if you're looking at 1982, 1983, we really didn't understand it because it was something new. Over a period of time, we understood that HIV, human immunodeficiency virus, was spread in blood and blood products. And so when we came to protective measures, we really came up with measures that protected us against blood. That's a dramatic example, but we've done a really good job by knowing how it was spread and instituting control measures. And now when we look at the number of HIV cases, they're very small and they're in high-risk individuals that continue to engage in behaviors that would spread the infection. But most people, most of the time, don't have to worry about acquiring that. So let's talk about respiratory infections. Respiratory infections are spread in respiratory droplets. We can sit down there and make up fancy names for this, but it's spit and mucus. I mean, that's really how it comes out. That's where the virus is. We've all been familiar with a close talker. We've all been around somebody who talks. As a matter of fact, if you're a child in elementary school, if somebody hasn't told you once, say it, don't spray it, then you didn't go through elementary school. You know exactly what I'm talking about. That's large particle droplet. That's when people sit down and particles of mucus or particles of saliva are put into the environment. These particles are large, relatively speaking. In our scenarios that we were talking about, 10 to 20 times the size of the viruses, and even more so, to be honest with you. They go out about 3 feet. They're heavy. Gravity works on these particles. So if I'm sitting down there and I cough, the material is going to come out about 3 feet. And for me, that's about from the tip of my nose to the tip of my finger. So that's how I can tell 3 feet, because I've measured it. That's 3 feet. So I know that's about what? So if I'm doing this, that's the range in which particle droplets are going to be spread.
Okay, so sorry if I may interrupt
Yep.
you. So that's a really great point, and I just
Yep.
want to follow up on the coughing thing.
Yep.
Is that a cough with or without covering the mouth? And then when you say the particles are going 3 feet, are you talking about the spit that we could see if you coughed on glass, or are you talking about aerosolized particles that are not visible to the naked eye?
Well, I'm talking about this more. I'm talking about the talking and the saliva that comes out of our mouth, and when we snort, when we sneeze.
Okay.
I'm talking about this large particle droplet. We're talking about 3 feet.
Okay.
We cough, we get into a slightly different scenario, and it depends. When we cough, we're certainly generating large particles. There's no doubt about it. But the thing that we do, just like a little aerosol spray can, you sit down and spray it. They're large drops. If you get an aerosol spray container and spray it, you're going to get it within a few feet of the spray can. But it's also going to spread at some distance away from you. And so when we cough, we create large particle droplets, and that's the 3 feet. They also then break down into much smaller particles that are hundreds of times smaller than the large particle droplets that will float on air currents. And that small particle spread, those are aerosols that would spread. And the problem with this is that in any particular instance, when somebody coughs, they're going to create large particle droplets, but they're also going to be creating an aerosol. And it's difficult to say in one particular situation that cough was only large particle droplets, and this one spread small particle droplets. So that's so large particle droplets, aerosol, and then the last one is contact. The example of this one, and I'm going to segue to a slightly different virus, are summertime viruses. You're probably familiar with it as hand, foot, and mouth. It's epidemic in the summertime. Most of you have had it, or your children have had hand, foot, and mouth. Hand, foot, and mouth disease is spread on surfaces, particularly doorknobs, bathrooms, because people don't wash their hands after they use the bathroom. These enteroviruses are spread by fecal-oral contamination. I know that's disgusting, but that's how they're spread. And they are on surfaces, and they stay there for prolonged periods of time. That's why these tend to have outbreaks in the summertime. We also see certain types of stomach viruses, noroviruses, spread during the summertime. We've all been familiar with outbreaks in Little League teams. That's a common one. There'll be a Little League tournament, and everybody gets gastroenteritis. They get vomiting and diarrhea from it. That's on the surface. That's contact spread. You get it, and you put your fingers in your mouth as well. Respiratory viruses can also be spread by contact. If you get the mucus or the saliva on your hands, you then have an infectious agent on you. The most effective way to transmit a respiratory virus, interestingly not, is not putting your fingers up your nose, not putting your fingers in your hand. It's rubbing your eyes. In the corner of my eyes right here, in the epicanthalus right there, is the nasolacrimal duct. When you're done watching this, you can get a magnifying glass. You can do it with your kids, have a nice lesson with them. You'll see a small little dot in the center of it. That's where your tears go, and they drain into the back of your nose. That's why your nose runs when you cry. They're connected. And the virus wants to get to here. It wants to get, I'm not touching my face. It gets up here. Well, the best way to get there is not by in my mouth or in putting my finger up my nose. It's putting it in my eye and let it drip right to where it wants to be. So that's an effective method. So just having it on surfaces isn't as important as getting it on your hands from a surface and then putting your hands to your face. That's why we're telling everybody, and I've done it my whole life, is that I try to keep my hands below my shoulders in general because I don't like getting sick and I don't like getting viral infections. So when we see viruses being spread, we see them spread by droplets, aerosol, and by contact. This particular virus does not appear to make it into the blood, and so that's not an issue. And just the last transmission method, just for everybody out there, there's no documentation of a pregnant woman who's been infected transmitting it to the infant, because that's another way we see transmission as well. So we're seeing this basically as a respiratory virus droplets, small particle aerosol, and contact. Put this in context with some other viruses. How does this match up? Based on the evidence, remember this is a novel coronavirus. This virus didn't exist in the universe prior to mid-October of 2019. That's important to remember. It's new. We're going to continue to learn stuff about this particular virus. The information that we have available to this point in time is that its transmissibility appears to be about what influenza is. Now, the difference between this one and influenza is the classic example of influenza spread. If you want to know there's influenza in a classroom, look at absenteeism. If a child in the middle desk in a class has influenza, now the incubation period for influenza is very short, about 24 hours. So if the child in the center desk has influenza, the next day the 4 seats around them will be absent because they have influenza. The day after that, the 8 or 12 seats around them, and you're going to see school absenteeism go up to 25 or 50%. If you want to know that there's an influenza outbreak going on, just look at absenteeism in school. As soon as you see absenteeism go up, you know that influenza is in the community. It doesn't appear that coronavirus is transmitted to that extent. But again, we have a novel coronavirus. Schools have essentially been shut down since the beginning, so there's not a lot of data to support it in the United States. There's some data in some other countries, which we'll talk to a little bit later. So we can sit down there and say, the jury's out on that one to a small extent, but it appears by everything we're saying is that it spread like coronavirus. It's a common cold virus. I mean, how are common cold viruses spread? If you're at work and your coworker has a cold and you get symptoms 4 or 5 days later, you don't wonder, did you get it at the grocery store? Did you get it at the restaurant? You know exactly where you got it from. You got it from your coworker that had a cold. And most frequently, you got the cold from somebody else in the house that had it as well. So as a sense, that's its spread. Now, what are some of the bad actors? You want to know how things really are? I was born before 1958. I'm not telling you how long before 58, kind of thing, you'll have to guess. But I had measles. As a matter of fact, if you were born before 1958, you had measles. You may say, no, I didn't have. Yes, you did. Measles is spread by small particle aerosol, and it remains suspended in the air for long periods of time. As a matter of fact, if I walked into your place of work and I was contagious for measles and nobody in your workplace had measles, I'm betting that 90% of the people in your work area are going to get measles, even if they were across the room. Even if they were in different rooms, if the ventilation systems were connected, they're getting measles. Measles is a respiratory virus. Measles is probably the most contagious virus to humans that we know of. So let's put that in perspective. There's another virus out there that we've gotten rid of. It's extinct on the planet. There's some in Moscow and some in Atlanta, but that's it. It's called smallpox. Smallpox is also spread by respiratory droplets. The last large outbreak occurred in a hospital in Germany in the 30s and 40s. And a person with smallpox walked into the entry floor of a 3-floor hospital, and it spread to people on both ends of the 3rd floor through the central ventilation system. Those are really contagious respiratory viruses. They're in a different league. They're in a different classification. They're in a different universe than coronavirus is. We're looking at something that I want you to focus on: influenza and the common cold. That's what we're talking about. That's the reference point we need to have.
Okay, so that brings me to the next question, which is there's been significant discussion regarding the various ways that people can avoid contracting COVID-19 and the ways that they can avoid spreading it to others. So let's start. Obviously, universal masking, social distancing have been at the center of the discussion. So let's start with masking. Does the current scientific evidence support that masks are effective in preventing the spread of the virus from one person to another?
Now, there's a common sense answer to this, and I want this to be common sense. If you're listening to this, I want you to sit down and realize that John's not an idiot, okay? John's not going to sit down there and try to tell you something that's kind of counterintuitive to you. I just told you about droplet spread, and we talked about, say it, don't spray it. And you understand what I'm saying. And there's a common sense approach to this, that if I put a barrier in between me and other people, that I won't spread it. And in general, that concept of a barrier between the infected individual and the uninfected individual is a really good paradigm. I mean, if you sit down there and you're someplace else in the world on a desert island and you're sitting down there and you see somebody has sick and you want the other people not to get sick, you want to put a barrier in the way. I mean, it's a simple common sense approach to this. Sometimes, though, the common sense approaches don't really play themselves out. And let's be honest about this. And I think it's important that we have some honesty in this. That if you go into a hospital with somebody that has COVID-19, and you're walking on the outside and you look and you see the doctors and the nurses go in, yes, you're going to see the doctors put a shield on, they're going to put a mask on, they're going to put waterproof gowns, and they're going to put gloves on. Remember, these are individuals that are going into a closed environment with somebody who has mechanisms that are going to increase the spray, the aerosolization of the virus into the environment on local surfaces, and they're on frequent contact with people known to have it. So I'm not going to be foolish and sit down there and say that you're going to go into a room and not wear these. I had chickenpox when I was a child, but when I go into a hospital room of a child that has chickenpox, I'm still putting the gown and mask on, because that's the protocol in the hospital. That's what you do in the hospital. There are people in hospital called hospital epidemiologists. I was one for a third of a century, and I would put those mechanisms in place too. The idea is protecting most of those people. The problem is taking that out and putting it into the environment out there. Wearing a mask, now first of all, the mask, the gold standard is an N95 mask. It's got particle size, filter size, that prevents the viruses from being transmitted. One of the problems with this, if you can sit down and look this up on your own, you can find the facts out for yourself, but the size of the holes in the N95 mask are actually larger than the coronavirus. As a matter of fact, if the coronavirus is an M&M, the holes in the N95 mask are peanut M&Ms kind of thing, about 2.5 times larger. So you can see the problem that particularly poses. The second one is that every N95 mask has to be fit tested. Just putting it on doesn't mean that it's working appropriately, and there's some elaborate procedures to sit down and fit test that as well to make sure that that is sealed around. And just to let you know, I have a beard. That will absolutely prevent any mask from making a seal upon me. It's just not going to happen. If you have a beard like this, you can't wear an N95 mask. You have to wear something else called a respirator. So the masks don't fit. So first of all, let's talk about the issue of aerosolization. Remember we talked about the virus can kind of waft in the air and go around. And that's past 3 feet. Whether it's 6 feet or 9 feet, we already alluded to the fact it depends on a variety of circumstances, as how many viruses are present, temperature, humidity, air currents, and exposure to direct sunlight. Direct sunlight rapidly inactivates coronavirus. So we have to put those into place. But the masks don't seal, and there's aerosolized virus in, and I breathe in. I am breathing that virus in, and where do we said we wanted to get? Right, in the nasopharynx, once you get in the upper nose. If I go, I've taken it up into my nose, and that's exactly where the virus wants to be. So we can see there's potential problems with using masks to protect me. If we get to droplet size, there's some sense that if I put a mask on, I won't be spreading those particular droplets. And there may be some truth in the short term from that if we look at it from a common sense point of view. The problem is that most of these masks are porous. That's the feature they all have, and they're going to saturate. If you breathe your air, when you go out in the wintertime and you go, the cloud of air, that's water vapor. So every time you breathe out, you're breathing out water. If you breathe in these masks for a long period of time, you're going to saturate the fabric kind of thing. And if that saturated material, if you're sick, then that material, the saliva in there, is going to have viral particles. And if you are coughing or sneezing, all you're going to do is be pushing that out into the environment around you. So there's some theoretical issues about masks as far as protecting others and protecting ourselves. Let's look at influenza again. We've talked about influenza, and there's a lot of data. Influenza's been around a long time. We have tons of data on influenza. And if we look at the data about influenza, do masks work? And the data is it doesn't work. Masks don't work with influenza. What works with influenza? Washing your hands. Hand hygiene. That's the one thing we know for sure with influenza. Despite what I told you, the one thing we know for any infectious disease, if you want to keep yourself from getting sick, wash your hands and keep your hands out of your face. Those are the most effective ways of preventing it. So if we look around the world, if we look at places around the world where there's been a discrepancy between mask wearing and not mask wearing, do we see a difference in mortality? And we don't. We don't. There's a number of countries around the world. We'll provide some information at the end that you can look up on your own. You can draw your own conclusions from these as well. But there's some data in the Scandinavian countries, and there's some data from South America where these comparisons are available. And you can draw your own conclusions from that. But just understand the mask poses some particular problem. And so as a consequence, be aware of it. Just understand the limitations of it. So that's a mask. The one way that I can tell you to not prevent an infectious disease, any infectious disease, but especially a respiratory infectious disease, stay home. Isolate. I already said put a barrier. The best barrier you can put is your house away from everybody else. If you're sick, don't go out. I can't say that enough. If you're sick, don't go out. If your children are sick, don't send them to school. Don't send them to preschool. Don't send them to daycare until they've recovered from the illness. And that's the best way to prevent these as well. We talked about keeping your hands out of your face. We talked about hand washing. The social distancing is a real problem, and I don't want to get into it. I'm just letting you know that if we went to European countries, social distancing is about 1 meter, which is a little farther than the tip of my nose to my fingertip. We've chosen 6 feet. I think the numbers are hard to sit down and find hard evidence to where they come from, and I would encourage you to look and come up with your own conclusions and try to find the information for yourself. But I think if you look hard like I have and some of my friends have, I think you'll come to some of the same conclusions that we've come to.
Okay, so just to reiterate that the standard for social distancing in European countries that's considered safe is about 3 feet, and the standard in the United States is 6 feet. And the science is pretty mixed or unclear as to whether or not either of those are actually effective, but that's what we're doing.
Yeah. Unclear. There's a nice study which we'll include in our bibliography. It's out of the Netherlands from about 2018. And they've looked at all these issues about how infectious agents are transmitted. And, the problem they came up with is we've already alluded to inoculum size. The example that I would use is imagine you have one of those little Velcro little things. They look like a dartboard. They have a little circle and they have scores on them. And you get the little Velcro balls. I don't know about you, but if you put me 15 feet away from one of those and you have me throw the Velcro ball, I'm probably going to miss it every single time. So, but if I have 40 of them and I throw them even from 12 or 15 feet away, chances are I'm going to hit it. Some of them are going to stick. So the first thing we need to do, talk about transmission of these viruses, how much is there? And we know over a course of infection that the numbers can start out low and then get high during the middle, and then they go down as it goes away and the immune system kicks in and eradicates it kind of thing. So you may have less virus present on day 1 than you do on day 2 or 3 than you have on day 6 or day 7. So first of all, when we want to look at these things, we have to control for how much virus is there. If I put an industrial fan as I'm throwing these little Velcro balls out there and I'm blowing a 40-mile-an-hour gust across it, chances are none of them are going to hit no matter how many I throw because the air current's affected as well. So that's something that we need to take into place. The third part with this is distance. If I get 2 inches away from my little target and I have one ball, I'm going to hit it every single time. That's where the social distancing comes in, is that the farther away you get, the less likely you are for these things to hit you. And again, it's a common sense approach, but and I encourage you to look at the data. We'll include some references for you can. You look for yourself and sit down and see how effective the social distancing is. But yes, there's a discrepancy between what other people in the world are doing and what we do in the United States. And there's lots of data out there for you to look at yourself, and you can make up your own mind based on the information.